So, Doc, would you like to begin? Will this also be a long lecture like the last one?
Oh yes, this afternoon was very long. In fact, we've reduced them. You realize we don't even cover 2/3 of the diseases, but we cover the major ones we would like you to know and leave you to explore the rest as you are learning. Because in the other subjects, you may explore some of the other diseases. So that allows you to read everything. We don't stop you, but if you see even in our reports, we put out more than we have covered in class so that it opens up your horizon. But we focus on the ones that give you direction as you are reading the diseases of the specific systems. Okay, so today we are continuing the story of hepatic diseases. And
recording in progress.
What is like a common pathway for the ones that we had talked about last week and even others that we didn't talk about, the metabolic problems, the toxics, the toxins that damage the liver, considering the position of the liver in metabolism. And now we are looking at the diseases that are common. There are common pathway for the previous ones that we've talked about. I keep on emphasizing that tissue is elastic. It's not static. You injure it, it reacts, it heals, it provokes a new reaction, an adaptive process, an inflammatory process, an injurious process. So the tissue is always responding to all this interaction to the environment around it. And for the main systems, the respiratory system, the kidney, the liver, we have common pathways of the various diseases that if you injure the kidney using this, if you injure the liver using these different types of injurious agents, there's a common pathway where they meet. After a diffuse injury and there's healing with fibrosis, there's a consequence that is common to the different diseases. And that consequence creates a new disease. That takes you back to general pathology. Each of those entities that we discussed are capable of producing a disease process. Some are physiological to help contain something, but an exaggeration of the reaction provokes a disease process. So today we are looking at a common pathway of injurious processes in the liver and the disease processes that they create and what we see. And when it comes to the clinical presentation and management, you hear more now from internal medicine group and pediatrics next year. Okay, so it's important that you go back and see that you have understood inflammatory conditions. We talked more of the infectious ones. We did not talk about the autoimmune ones and such, or the ones that are provoked by other non-infectious agents. But inflammatory diseases, then alcoholic liver disease is the only one that we touched on that wasn't inflammatory. And then we shall continue with the story with liver cirrhosis, portal hypertension, hepatic failure, and hepatocellular, which is a continuum. So those are like the next consequences of the previous things and many more that we did not include that you might have heard from my other colleagues. Okay, I mentioned fulminant hepatitis, where you get massive necrosis, and that's how small the left lobe can look. The right looks, I mean, you're not even sure it can be 500 grams, 600 grams, and we say that a liver can be very large. And this is common with viral infections and toxic damage, either by drugs, which you might be using. So a colleague can cause an iatrogenic disease where you have this massive. But often trying to commit suicide, that's when they have this toxic injury to the liver where you have massive necrosis. But viral, more common. It's not a common thing. I've only seen one, I have to admit, where I had to do a postmortem. Okay, I mentioned about schisto. We said the worm doesn't do anything. Oh, I forgot to share the image. I have a good image of the worms in the liver. And then these are the eggs, provoking an intense chronic inflammatory process. And a chronic inflammatory process is productive fibrosis. So you start distorting this distortion of the architecture that is very characteristic around the pipestem fibrosis. We talked about fatty change because of alcohol and other things. And the spaces are where the fat is accumulating, fatty acids are accumulating there and creating that appearance. Okay, so now we start with cirrhosis. It is a common cause of death on its own. I've said it's a pathway. The risk factors, the causes include the things we've already talked about. So it's like a common pathway, and it's a common cause of death, even in our setup, and also a common cause of liver-related deaths. You can die, a patient can die from severe fulminant hepatitis B, chronic hepatitis B that's persisting, or alcoholic injury. But if they develop cirrhosis, then that now can also be a cause of death. It is a chronic liver disease, which is characterized by a diffuse injury to the liver. It's not localized. If it's a localized thing like an abscess, then we don't talk of cirrhosis. It has to be a diffuse, where there's chronic irritation associated with healing by fibrosis. So it's an end stage, just the way we talk of end stage chronic kidney disease. End stage of chronic liver disease, it's diffuse, and there is bridging fibrous septae. That is because of healing with fibrosis. Liver is stable. Once it's injured, it's provoked into regeneration. So we see parenchymal nodules, which happen because the cells are proliferating in the process of regeneration. So not only do you see the fibrous tissue, which is a consequence of healing with fibrosis, you also see the other element of parenchymal cells regenerating and forming nodules. But the architecture is distorted. You get fibrosis nodules, but they are not in the usual arrangement. So there's the architectural distortion. So we talk of disruption of liver architecture. Often when architecture is disrupted, function becomes disrupted. Okay, and what is the pathogenesis? When there's hepatocellular death, either by viral damage, toxin damage, metabolic damage, then you get deposition of extracellular matrix, and that provokes the rest of the process that happens, where we have vascular reorganization, deposition of collagen in the healing process, and this collagen is deposited in the space of DISE, which replaces of the vessel wall. And because of that, where you have fibrosis, angiogenesis, then you end up with a distortion of the architecture and new vessels forming in the portal region, the portal tracts region. So you get new vessels that form. And of course, there's the hemodynamics are affected. The hemodynamics are affected. And because new sinusoids are being formed, the capillaries are being formed, they lose the fenestrations. And so the function is not as it should be, where you get free flow of fluid and molecules across the fenestration. So there's regeneration, but not the same structure. And because of that, you end up with distorted function. It also provokes the proliferation of the stellate cells, which are the ones that are thought to become fibrogenic and deposit the collagen that gives the nodularity that we see. And this happens because there's chronic inflammation. And when there's chronic inflammation, you have the cellular components that come into play and release of cytokines, the tissue necrosis factor, lymphotoxin, interleukin-1 beta, lipid peroxidation products, all those inflammatory things that we've talked about that are thought to play a part. And these have an effect on the Kupffer cells. Kupffer cells are the macrophages that we find within the sinusoids. Endothelial cells are affected. They line the sinusoids of the hepatic plates. And then we find that there's a bile duct epithelial, they affect the bile duct epithelial cells. In the triads, you have bile ducts as well, transmitting the bile into the gallbladder. And then, of course, the hepatocytes are also affected by this. And there's disruption of the extracellular matrix and direct stimulation by the toxin. All that affect these cells, which are part and parcel of the normal anatomical arrangement of the liver cells or the liver, let's say the organ, and you get a distortion. You get a distortion so that if we are looking at the histology of such a liver, we see a diffuse nodularity because of the fibrosis, and we see an ongoing inflammatory process. The cytokines attract lymphocytes to the site. We also see that we have regenerating nodules where you cannot see a central vein and you cannot see the portal triads. You only see them where the fibrosis is, and they look like they are distorted. They don't have the normal arrangement of the triad. So it's a diffuse pattern that you see across. And you may have macro and micro nodules depending on the rate at which there's regeneration. People have tried to associate the different toxins with the appearance, but it's not an absolute appearance. So we talk of macronodular cirrhosis and micronodular cirrhosis, and we have that in the museum. Often it's a mixture of both. You see macronodules, micronodules, because as a chronic inflammation, there's inflammation and healing occurring at the same time. It's a productive process, and you get both inflammation happening and repair happening. So we end up with the nodularity that one sees. Okay, so that is cirrhosis, which is a common pathway of the alcoholic injury, alcoholic hepatitis. When it's chronic, it's been there long enough, cirrhosis ensues. Then viral hepatitis, be it B, C, and other viruses. And then non-alcoholic steatohepatitis, we mentioned that last time. And of course, something we are not mentioning today, biliary disease. The disease might not be hepatic, but it may be the bile ducts. When you're talking of the tracts, you have the vasculature and both arterial and portal, and then you have the bile ducts. So when you have a disease of the bile ducts, you can also get cirrhosis because it will happen around the triads. And then, of course, any other deposition that you get deposition into the hepatocytes and sometimes even into the Kupffer cells. So like in iron overload, when we are talking of hematochromatosis, which you'll hear more in chemistry and hematology, then we can get excess overload within the parenchymal cells, resulting in damage of the cells. There's only so much that each cell can store. When we are doing liver biopsies, maybe you have seen when you do bone marrow biopsies, you try to see the iron store in the liver, well, in the marrow. Well, we also do iron stores in the liver to see what is happening. And when there's iron overload, for whatever reason, either because of metabolic derangement or there's too much transfusion, then some of it is stored in the hepatocytes. And when that happens, and the Kupffer cells, and when that happens, you get damage. And if it is severe, like if it's a congenital issue, then the liver cells are damaged. We also have those other storage diseases. Over time, there's damage of the parenchymal cells, and because it's a diffuse process, then it provokes the same thing. So you can see there's so much to talk about. We've only chosen very few and not gone into the other. Even in the biliary, when you're talking about the biliary system, you will not go much into this cirrhotic process, but it is a cause of cirrhosis also. It can be a cause of cirrhosis. Any structure in the liver, especially between the ones that form the structure of the liver, can be a cause of, can have this common pathway of having cirrhosis. Okay, so that's one common thing. What is the other one? Hepatic failure. And hepatic failure can result from the other processes that we talked about, or it can be acute, provoked acutely by toxins and what have you. But it can also be a chronic consequence of the diseases that we talked about last week and many more. Okay, when we have failure, it means that the cells have been damaged to a point where the liver reserve is overwhelmed. It cannot maintain the function as expected. And we have both acute, subfulminant, and chronic. In acute liver failure, we talk of liver failure that occurs within 6 months. Yeah. So anything within 6 months, somebody was given medication 6 months ago and has not been well, has been having jaundice, which is increasing over time. So if it's less than 6 months, we'll consider it an acute liver failure. So it doesn't follow the same rules, with the other diseases, which are usually a matter of days and weeks. So for the liver, we are talking about 6 months. If it is very severe and it occurs within less than 3 months, 2 weeks, we talk fulminant. And if it's 3 months within the 6 months, then we say that it is subfulminant. Okay, what are the things that can provoke this? Drugs. I'm emphasizing drugs because you've just finished pharmacology. You will do therapeutics in the 6th year. And you always have to be aware that any prescription you give can be a death sentence or can be a chronic problem for the patient. So is it worth prescribing that medication? Young doctors are very enthusiastic in writing prescriptions, but we have to be aware that when you're prescribing, that the patient doesn't have an underlying liver problem, underlying kidney problem that can induce failures of these organs. So drugs is the common, and especially acute, can be a cause of common acute failure. The patient I had to deal with had been given, initially they thought she had hepatitis, then she was given drugs. So at the end of the day, we were not sure, but we thought that two things worked together and gave her fulminant or massive liver necrosis due to the hepatitis that was there and the drugs that she ended up getting. So drugs are a big problem, especially the ones prescribed. It can also be self-administered that cause massive damage to the point where the liver doesn't recover well. Instead, there's a healing with fibrosis, and they end up with, even before the healing with the fibrosis, they end up with liver failure. Exposure to the environment, the inhalation or ingestion, and it can also be a problem. Of course, you are aware that paracetamol, if you get an overdose of paracetamol, then it can cause a massive liver necrosis and failure. Halothane, there are patients who react to halothane and go into liver failure, and also carbon tetrachloride. Some of these things are not used so much, but you realize we have the TB treatment, which can also cause hepatic failure. So when you are asking the history and the testing, doing the liver function test, the renal function test, you are making sure that by the time you are giving the patient medications, you are not tipping them over, because they are probably functioning on the reserve. And now if you add increased demand on the hepatic failure, very critical when you're prescribing. Of course, if they have a history of chronic liver disease, you may be able to demonstrate that, or they may have history to that effect, then you are able to appreciate, and if you follow them up, the ones who are not able to clear the virus, we say that some of them are DNA viruses that get incorporated into the host nuclear DNA material, and that can progress with the time into it can progress into acute on chronic liver failure. Autoimmune hepatitis, there are those who, for some reason, start damaging their own liver, and these ones can also go into chronic liver failure. Usually there's something to tip them off into the failure. It's been there, progressing, and then something tips and they go into the failure, usually like an acute on chronic. Okay, it is possible to have liver failure without cell necrosis. Most of the other ones that we are talking about, there's disruption, total destruction of cells and resulting in failure, but you can also get dysfunctional. You get the cells becoming dysfunctional without necessarily being necrotic, and they go into failure. And what happens is that there's interference with the oxidase system or the mitochondrial oxidative phosphorylation. And what happens is that then the liver is not able to cope. And one of those other areas that you pregnancy, fatty change of pregnancy can cause liver failure. You have too much infiltration of fatty acids into the cells, the triglycerides, without necessarily destroying the cell, but you see they're occupying space and making that cell dysfunctional. And that makes them go into failure. The organ can't cope. So we talk of a failure. Not because the cell has been destroyed, but because there's an infiltration that makes it impossible for the cell to work, or there's a freeze of the oxidative mechanism that doesn't allow normal oxidation to happen. Okay, so how do they present when they have hepatic failure? It's characteristic. Bilirubin metabolism, the liver is key, and therefore what happens is that there's accumulation of this pigment, which is derived from the breakdown of hemoglobin, and so there's staining of the sclera, especially of the eyes. You're able to see the sclera, and you can see that there's deposition of the bilirubin. The liver is not able to function. The yellowness is that it's the excretory function of the liver. So you find that even the secretory function, so there's no production of albumin. The liver is the one that produces the albumin. And when there's no production and it's being utilized, then the oncotic pressure is lost and we end up with edema, accumulation of fluid in the tissues. So they present with the massive edemas because they have hypoalbuminemia. And then they are not able to detoxify the ammonia derived from metabolism of proteins, liver being key. So it's not able to metabolize completely, and you end up with accumulation of ammonia. And this is terrible because it now has effects on other organs like the brain. So now they acquire a new thing because the liver has failed. And then they end up with fetal hepaticus, and that is because there's formation of mercaptans in the colon and reabsorption, and that gives them fetal hepaticus. They are not able to metabolize estrogen, so there's accumulation of estrogen in the blood, and we end up with palmar erythema, spider angiomas, and hypergonadism or gynecomastia in males. And is it hyper or hypogonadism? In males, you see gynecomastia because of the estrogen that's not being metabolized. So you ask yourself, where is that estrogen coming from? It's coming from the adrenal gland, the cortical layer. Sorry, I have a plane flying over. The cortical sex hormones. So there's some hormones being produced by the adrenal glands, metabolized by the liver. So when the hepatocytes can't function, then there's accumulation. So you either get accumulation or reduction because there's no production, or things can't be detoxified, so you get that. Liver has, you have to go back to the function of the liver. You have to go to the physiology of the liver, and then you're able to understand what happens when somebody has hepatic failure. Everything that the liver does doesn't happen, and so you get the consequences of what is not happening. Okay, because we can't excrete the bilirubin, like I said, into the gallbladder, then you get accumulation of also the bile, and we have those bile salts as well, and you get not only the bilirubin but also the bile salts, which go together. Okay, what are the clinical features? For some, they don't present with anything. They are asymptomatic. And usually it's because there's still some function of the hepatocytes that are still there. But often they usually have anorexia. They are not able to tolerate foods. They are not able to tolerate fatty foods, and they don't have any hunger. And often it's because they also have other associated symptoms, not just the hepatocellular failure. They also have other associated symptoms, as we shall see. They have weight loss because they are not where there's movement of glucose and the digestive products of proteins being stored as fat. So there's the loss of weight as well because there's disruption of the metabolism. What is this now? Is it a mix-up? Okay, you can also get hepatorenal failure. I think that hepatic failure is hepatorenal failure. The failing liver, as it progresses on, draws on the kidney, and you get a hepatorenal. So you get two organs failing. Starts with the liver, and because there's buildup, the buildup of these metabolites, toxins, affect the kidney. And also get the same toxins causing the other major organ to fail, the lungs. So you get either a hepatorenal or a hepatopulmonary syndrome, where one organ fails, draws in the next, and you can get multiple organ failure, but they may present with that. What brings about death? In fact, this cirrhotic morbidity, not necessarily mortality. They are sickly. They cannot be able to do their day-to-day activities, and therefore they become dependents. And if you get a chance to go to the liver clinic, just have a look at these patients. They're usually miserable patients, very much like the kidney ones, in that, yes, they are walking around, they look like that, but they just look unwell, anorexic, malaise, and generally quite sickly. So they can end up with progressive liver failure, leading to death, or a complication of the portal where they end up with portal hypertension. We said that because there's disruption of the architecture, there's disruption of the vasculature and the hemodynamics, and that leads to portal hypertension. And portal hypertension has its consequences and can therefore lead to the death of this patient, especially from bleeding. Then we have some of the patients who eventually progress. We said the things we're talking about are progressive common pathway diseases. So from cirrhosis, then this they may survive despite all these other things that happen, and eventually a small percent of them, about 1 to 6% of them, develop hepatocellular carcinoma. So you can get hepatocellular carcinoma in the background of liver cirrhosis. And that liver cirrhosis started from something else, was a consequence of something else. A few of the patients can have cryptogenic liver cirrhosis. We can't find the primary cause. We can't find the cause of that cirrhosis. And unfortunately, the problem of cirrhosis is that if they live long enough, escaping the rest, then some of them may end up with hepatocellular carcinoma, which then leads to their death. Okay, the complications of hepatocellular failure is encephalopathy. We said that it can lead to the failure of other organs, which I have already mentioned. When the liver is unable to deal with the ammonia, then we get it affecting the brain, and the patients end up with encephalopathy. They go into coma, or they are semi-comatose, and that is because of poisoning of the brain, and there's disruption of the neurotransmitters in the brain and even the neuromuscular system. The hepatorenal syndrome, we said that the liver fails and the kidney follows, and it can be precipitated by stress factors such as secondary infection. Of course, they are still living in the same environment we are living in, and therefore they're exposed to things like infection. All that reserve, then it means anything that comes your way, you are hit by it. Just like the patients who don't have immunity, whatever comes their way hits them. But when they have immunity, they're able to contain it. It's the same thing with these organs, these key organs. You get a disease process, you are able to withstand. A good example is the guys who are getting COVID. If you have no underlying issues, you may recover well. But if you have other underlying lung diseases, then it means that your function is overwhelmed very fast. And some of those things are infection, a GIT bleed, and they can have a GIT bleed because of portal hypertension. They can get a GIT bleed because of portal hypertension, varices that bleed. And so that precipitates them to have a hepatorenal syndrome. And of course, if they have to have a major surgical procedure. Hepatopulmonary syndrome, where the liver leads to the respiratory failure, and they end up with hypoxemia, and even intrapulmonary vascular dilatation, simply because of retention of some of these toxins and affecting the way oxygen is carried by the blood. Okay, the patients who have this hepatopulmonary syndrome develop a ventilation perfusion mismatch, or they may have a perfusion defect, diffuse perfusion defect. They are not able to perfuse the lung adequately because of the effects on the vasculature. Okay, now we come to hepatocellular carcinoma, the most feared of the diseases of the liver and the consequences of liver. And what are these things we are talking about? I have put the liver there. These things vary. These things vary. This was the Globocan 20, which one? 2017. Yeah, okay, I don't remember the exact month, but it was the latest one. And you can see where the liver is placed. I was reading my literature, it was showing that currently it is placed 6th. This is the world figures. Breast is first, esophagus, cervix, prostate, colorectal, stomach. But now they are saying liver is number 6. And at the time I had this, the liver was number 8. And that means that something has been sorted out here. I'm not sure which one has been sorted out. I'll update my figures. So when you read, you may see there's an interchange. So you can see that we are talking about an organ that is critical when we have liver hepatocellular carcinoma, because it contributes that much to the world. And here we have the Kenyan figures. Breast is first, cervix, and then liver is still at top 10. And so we cannot ignore liver, even when you're talking about malignancies, because it contributes quite a bit. And this is just in the ranking in terms of prevalence. But in terms of deaths, liver cancer is higher than many of the others. It's a lethal type of malignancy. And therefore, if you can prevent all the things we've talked about, can you prevent hepatitis B? Can you prevent hepatitis C? Can you advise people about alcohol? Can we take care of aflatoxin in our food? Why? Because when somebody has hepatocellular carcinoma, it's fairly high up in the causation of death. Like esophagus is number 2 in the causation of death, and the liver pretty high as well. Okay, and we cannot escape. You realize we have underlying risk factors to hepatocellular carcinoma. Okay, there it is. I didn't know I had it. The cause of death. So it was number 8, but you can see when it comes to cause of death, it goes high up. So it's an important organ to consider when we are talking about malignancies and the burden of disease in the nation. Why cancers take quite a bit of budget in our health sector. Of course, we have the infectious diseases, and when we're talking about infectious diseases, hepatitis B is there, and it is one of the risk factors that we are talking about. Okay, these are American figures from the textbooks. You can read from wherever you want. They won't be very varied. We have given you the textbooks to read. So it's fairly common in the US. It's also fairly common in our setup. We don't have very good what shall I call it? Registries to be able to share this. I hope we shall make some of you interested in epidemiology so that you become the people who project for us and tell us which is the important diseases, so that you do epidemiology and specialize in that area. So with our Kenyan figures are very lucky. You can even see the trouble we have with COVID. But now COVID, we have put a lot of resource. And even with that, we still struggle before we can produce our own statistics. So we don't have very good statistics about some of these diseases. And I think it's because we don't have people who are interested to be able to pursue that career. So if you're wondering where you can find work, take up the epidemiology when you finish. Okay, so about 626,000 cases per year in the US. For them, it is the third most frequent cause of cancer deaths. For us, we don't even know, but we have the world figures. Most of what we have are just projections. They are not true figures. Even collecting the data is a problem. And it is said to be increasing very fast because of hepatitis B in the developing countries, and we are part of it. In fact, we are among the countries with the highest rates of hepatitis B. So this is going to become more and more important as we control CA cervix, CA prostate, and breast. Okay, the ratios vary. You will see some books talking 3:1, but males are more affected, and males have higher risks of also are affected by the other, especially alcohol, and that is why we also have more of them having hepatocellular carcinoma than the females. Then those are the things that we have already mentioned: the viruses, alcohol. Then we have people who just have storage of fat in the liver for no reason, not related to alcohol. And this NASH, it's called NASH, has an increased risk of progressing into cirrhosis and thereafter into hepatocellular carcinoma. Metabolism, tyrosinemia, and other non-alcoholic fatty diseases and storage diseases. These are people who can do anything. They're born with enzyme defects. So because of the metabolism that we are talking about, they lack one enzyme that allows to convert these products into the form they should be in, and they end up remaining in the liver cells and damaging the liver cells. So anybody with those things like hemochromatosis, they can end up with that. So for us, hepatitis B, very important. Alcohol and aflatoxin, those are among the top things that contribute towards our country. In the West, hepatitis C is an important risk factor. Alcohol is a risk factor. They don't talk of aflatoxin the way we do. And aflatoxin affects the maize, and that is one of the things. So you can see we are at the mercy of the environment. And yet we have agricultural officers who can advise our people. Our people have been to school. We have good rates of literacy, yet we still expose ourselves. Somebody knows the maize has aflatoxin and sells it. Somebody knows they stored the maize, it got aflatoxin and it's condemned. Instead of disposing it the right way, they throw it where the desperate go and pick it. Or those who think it is okay, feed the animals. Forgetting you'll eat the chicken, you'll drink the milk. So the aflatoxin still comes back to the human beings. So I mean, I don't know what it will take for us to behave like responsible human beings. Okay, we talked about hepatitis B and the X protein factor, which is a transcription activator of multiple genes that cause the transformation, or actually it can also be a direct effect when it's incorporated. Hepatitis C doesn't have the same direct effect, but it is thought to be also activate somehow. Okay, the countries that have been successful with hepatitis B vaccine, I think we can say our country has fairly been successful because it's a childhood vaccine. We put it into our KEPI, Kenya Expanded Program on Immunization, Childhood Immunization. And it has been shown in the countries like Taiwan that it brought down the rates of hepatocellular carcinoma from 10% to 1%. And when you see that and you consider how much national wealth you have to use to manage the cancers, then it becomes worthwhile to introduce that kind of vaccination program. But you can see we are at the mercy of the countries that produce vaccines, the generous countries. We should be able to take care of our own business and produce our own vaccines. Okay, what do we see when somebody has hepatocellular carcinoma? It can be grossly, it can be unifocal. It can be a single growth. But because we said it comes in the background of a diffuse disease, then it can also be multifocal. And most horrible, it can also be diffusely infiltrating, so that you get like almost the entire liver is tumor. The tumor has infiltrated and replaced the whole liver. But most of the time we actually see unifocal. When we see multifocal, we have to consider that it could be metastatic. Liver is a common site of metastasis, and because it has a double blood supply, it gets multiple deposits as mets. And therefore, when we have a multifocal hepatocellular carcinoma, we have to be careful that it's not a metastasis. But diffusely infiltrating, every now and then, we see large tumors occupying almost the entire right and left lobe, or even just one lobe. Okay, usually the area with the tumor will appear paler because the cells are not normal. Liver usually has a nice healthy red color, but we said that it can be in the background of cirrhosis, and in the cirrhosis, it will also be pale. We have beautiful pots, please make sure you see, and in fact in them you will see tumor in the background of cirrhosis, and others where the tumor, there's no background cirrhosis. And then you compare with the ones that has multiple metastatic deposits. But please note that we can also have a multifocal tumor. Because cells produce bile and they are trying to replicate normal hepatocytes, we get some tumors that have bile staining. So they have a greenish hue or a yellowish hue because they have the bile being produced by the tumor. And usually it will be in those that are well differentiated because they've reached a point of even being able to produce that. When they are not, and because they are big, large masses, we can also see necrosis. Microscopically, we see vascular invasion, which can be extensive. We see one nodule with irregular edges, but then when we cut tissues around it, we see that there's a vascular invasion and intrahepatic spread. And that can explain how you end up with a diffusely infiltrating tumor. But even when it is a nodular thing, unifocal, multifocal, you find that we can have lymphovascular permeation and spread into the surrounding normal-looking liver. Okay, it goes into the surrounding nodes, the perihilar nodes, the peripancreatic nodes, and the para-aortic nodes. And the patient can have these nodes compressing the portal hepatic vein and actually now produce a symptom from the pressure effect, And when we go in, we find that they also have a liver tumor with nodal mets. Otherwise, these nodal mets can also come from other tumors and create problem in the liver. So when we see perihilar nodes, then we have to wonder whether it could be from other tumors other than the liver itself. On microscopy, it can resemble liver. It can look like liver forming cords, which we call trabeculae, or it can form flower-like arrangement that we call acini, or can even have a gland-like appearance. And this pseudoglandular can be tricky because it can be mistaken for a metastasis, or show none of that and just be pleomorphic, or even spindle cell. When they're like that, we are not sure what is happening and becomes a problem. But when it's trabecular, then it makes it easy to diagnose. And it has a characteristic look where you have endothelial cells around this trabeculae, the acini, and it tries to replicate the sinusoidal arrangement around the hepatic cords. We have a special type, a histologic subtype that is called fibrolamella. This is an interesting one because it constitutes about 5% of all the hepatocellular carcinomas, and it's more common in young men. Unfortunately, even the other hepatocellular carcinoma is more common in men. But this fibrolamella one, because it's such an unusual appearance, is more common in young men, and they're usually young. Let me warn you that hepatocellular carcinoma is seen in young people. We can even see it in 25-year-old. We have seen them in these young people. And the horrifying one is when we see in the pediatric age group, and we have seen a few. But the fibrolamella is in the young men and women, and can also be seen in patients who have not don't have a history of an underlying liver problem. They don't have a chronic disease process, but they just present with this tumor. Looks like a scar. It looks like a scar in the liver, but when we look at it, we find spindle cells because it has dense collagenous tissue. So it looks very unique, like a fibrotic scar tissue. But when we look at it, we see malignant cells, and they can be cords, nests of cells, which form parallel lamellae within dense collagenous stroma. The cells have a spindled look and are quite unique in that they don't resemble. In the classical one, the cells resemble hepatocytes. Only when they are pleomorphic are they large and quite abnormal. But like the trabecular one, they just look like slightly bigger liver cells forming thicker cords that we call the trabecular. Okay, I put in that because when you're just told, you have no idea what somebody's talking about. This is normal liver. You can see the cords of hepatocytes. They form 2 to 3 cords of cells, and in between you have the sinusoids. So if it was congested, we would see widened sinusoids. But next to it is something that is not the same. And this is tumor. This was a core biopsy. When they suspect tumor, they usually do core biopsies, and you can see. So this is a cord, and that is a cord, yet it's much bigger than that. So these are trabeculae. It's trying to resemble the liver trabecular pattern. And so we talk of microtrabeculae, macrotrabeculae. From the histology point of view, we try to associate the appearances with causation. So don't worry about that. But what we look for is it trying to resemble liver. And if you look at these cells, they are not very different from that. The only thing is that they have features of malignancy. There's increased nucleocytoplasmic ratio. The nucleus are more dark. They are more varied in size. We don't have much of the sinusoids in between. We have thick layers of cells. There are several layers, yet we know that this one, they should only be like 2 or 3 cords of cells. And this is a higher power of that one. So that's how we are able to say the tumor resembles the liver and it has a trabecular pattern as opposed to any other type of pattern. Okay, I put in that so that you can see what we actually see. Now, this one is forming glands. And we say that the liver can also form a pseudoglandular pattern. But this one is completely different because even the cells are not like the other ones that we were seeing here. Here, they are slightly different. They're even forming secretion. And this was a metastatic glandular tumor. When they are glandular, the liver carcinoma is a glandular tumor, and therefore it has a vague resemblance to metastatic glandular tumors. This can be from stomach, colon, ovary, any of those can go to the liver, being a common seat of metastasis. Okay, how do we tell the difference? Suppose we are not sure what that is happening. Is it liver primary or is it liver secondary? Is it something else coming to the liver or is it starting in the liver? Then we do immunos, because this is H&E. We do immunostains, and on this side it's negative. The HEPA stains for the liver cells. Here it's negative. We are looking at antigenic material that resembles the liver. This one is negative, but here the core went through normal liver and through the tumor. The tumor is negative, but the liver cells are positive. And you can see how they form these cords of cells, the trabecular pattern, and in between the sinusoid. So this is normal liver, this is the tumor, and we say it's negative, and therefore not a liver primary, so a secondary. And from there now you go looking, where could it have come from? If it's the thyroid, what do you need to do? If it's the lung, what do you do? If it's kidney, which immuno do you do to confirm what it is? Okay, what is the clinical presentation for patients who have hepatocellular carcinoma? Definitely the cirrhosis. It can also be ill-defined upper abdominal pain. They're not sure. They just say they have a pain on the right side. Then they have malaise, fatigue, weight loss. And you realize malaise, fatigue, weight loss, marked weight loss, cachexia. That is a common thing with malignancies. It is not just the liver. And yet we've said even a cirrhosis can give you the same thing. So malaise, fatigue, weight loss, like any other cancer or any other chronic disease, and then an enlarged liver. But if it is in the background of cirrhosis, cirrhosis can give you a large liver, a small liver, or a normal liver. So when it is tumor, it can be large, so you can get an enlarged liver, or even just abdominal fullness, and the fullness may be because of the liver itself or a secondary effect of ascites. So what investigations would one do? Commonly, there's a serum alpha-fetoprotein levels, and 50% will have false positive if they have cirrhosis, but it's a good baseline. And if it is positive, then we can use it to follow up, monitor. You've heard a lot about tumor markers. They are not diagnostic, but they are nice to you're following up the patient. Okay, so alpha-fetoprotein, and it remember that it can be positive in other conditions such as cirrhosis and liver necrosis and those other ones. Okay, as the liver enlarges, as the tumor enlarges, it's replacing the normal functioning liver, and therefore there's hepatic derangement, hepatic function derangement. And if you do the LFTs, then you're going to see that the other serum, the other enzymes are deranged. Where do the metastases go? They're commonly to the lung, but it can also go to other sites. It can go to other sites that even contribute to it. It acquires mets from lung, and it also contributes to lung as well. And then what eventually kills these patients? You realize we like tracking the sequence of events. So a person has this, what would now kill them? They have lived with it for a period of time. What now brings death? One is extreme cachexia. The fact that they have the humoral effects of the substances produce the tumor that make them anorexic. And then on top of that, affecting the metabolism. But when we're talking cachexia, it is a humoral effect, not a direct effect. And they can just die from that cachexia. They can also die from other consequences, such as bleeding into the gastrointestinal system. And how does that happen? If there's portal hypertension, then they get a consequence of esophageal varices. This can rupture. They can rupture spontaneously, swallowing, and that can give massive bleed. And you know that if you have massive hemorrhage, be it intra, external, that can lead to shock and death. So they can also die suddenly because of bleeding, not necessarily from the tumor, but the consequences. So this can lead to sudden death. On the other hand, like the ones who get the very diffuse one, or in the background of cirrhosis, they can go into liver failure and hepatic coma. Actually, liver failure and hepatic coma have very high mortalities, and so can lead to sudden death, or can progress and eventually die off from these effects and not the direct cancer itself. Now, every now and then, rupture. A person didn't have a background liver disease, chronic liver disease. They end up with a large tumor, and it is close to the capsule. You know, the capsule is tough and strong, and if they bleed into the liver, they cannot have massive hemorrhage. But if the tumor is close to the surface and it erodes into the capsule, they can have sudden massive hemorrhage. And these are the ones who die peacefully. So you find them dead. They didn't have jaundice. They didn't have ascites. They didn't have anything. And what happens is that a postmortem is done, and you find 2 liters of blood into the peritoneum. And what happens? It's because of rupture of this tumor. It's a common, let me not say it's that common, but we've seen enough. We've seen enough to realize that you can get that. In some of the patients, they know that they have a tumor and nothing is being done, then it ruptures, but others don't even know. They were feeling sickly because the tumor produces something to make you have malaise and what have you, but they don't know what's happening, and then they bleed. And at postmortem, we find that they have that. And in fact, at postmortem, there's a way of telling whether we think the large tumor close to the capsule that has ruptured, whether it's a MET or whether it is a primary liver tumor. When you go to the mortuary, ask the colleagues to show you, to demonstrate that, how they tell before, because you see at gross, you can only suspect and then confirm at microscopy. Okay, the 5-year survival rate is very poor. Diagnosis of hepatocellular carcinoma is like a death sentence. Majority are dead in 2 years. In fact, about 80% are dead in 6 months. So people have all sorts of prediction, but the bottom line is that 5-year survival rate is poor. Majority are dead in 2 years. Don't make a prediction for any patient you come across, because you can't tell. Some survive, but generally very poor. In fact, there's quite a bit of advancement, but you'll find as you rotate in the oncology wards that this is a tumor nobody wants to deal with because the outcomes are very poor. We said it goes into the lymphovascular space, so it spreads very easily. But if they're small tumors, they've come up with all sorts of ways of dealing with it. Surgery wasn't very good, but because there's chemo now, some do ablation. They try to excise it, or embolize it, or using radio frequency, using microwave. There are all sorts of things to try and kill the tumor, but the outcomes are still bad. The outcomes are still bad, and you will hear that from the oncology guys, that hepatocellular is one of those bad tumors. Okay, so that is hepatocellular carcinoma, a terrible tumor, fairly common in our setup, and too many risk factors within our setup, and therefore one has to be careful even when you're prescribing some of the medications. Okay, how about the other consequence of these chronic liver diseases? Portal hypertension, we've already mentioned. Cirrhosis is one of those that can bring about portal hypertension. And what is portal hypertension? Hypertension, you recall, is any increased resistance to blood flow, the systemic type. We talked about the systemic and what do we call that? The one involving the right side of the lung, and now we have the portal hypertension, pulmonary hypertension. Now we have portal hypertension, and this will be because of altered architecture, and that is because of the chronic disease healing with fibrosis. The fibrosis distorts the vasculature. There's regeneration without the fenestrations and all that, and they are grouped into prehepatic, intrahepatic. This is where some of the other disease processes that I won't talk about, but you might hear others talking about it, and you are free to read. Obstructive thrombosis. Then you wonder, thrombosis of what? Thrombosis of the portal vein. But can it be also in the hepatic artery? Yes, it can, but the vasculitides that affect the artery are not as common as the obstructive thrombosis. It sounds simple. It has obstructive. We had a young male who had this, and I tell you, we watched him dying, and we could barely make the diagnosis. And what he had was obstructive thrombosis of the portal vein. It can happen. It can also, instead of obstruction due to thrombosis, it can also be narrowing of the portal vein. A problem with a vessel wall and you get narrowing, or it can be massive splenomegaly, pulling of the blood and causing backflow pressure. Okay, what are the intrahepatic ones? Cirrhosis, we've also mentioned. Pipe stem fibrosis can contribute, although it's not as bad as cirrhosis, because we still have some functional parts. But it is notorious for portal hypertension. Schistosomiasis is notorious for portal hypertension, even if we don't have cirrhosis. And that is because the major vessel walls become fibrosed, and that contributes to intrahepatic, increased intrahepatic pressure. Massive fatty liver, the kind that is NASH related, can also cause portal hypertension. And you think that storing triglycerides in the liver is not a big deal, but if it is massive, then it can result in portal hypertension. The dynamics of the blood flow within the triads becomes a problem. Okay, diffuse fibrosing granulomatous diseases, TB, you can get TB in the liver, you can get other granulomatous fibrosis, are usually converted into fibrotic scars. So the minute you come up with a disease that causes fibrosis, then you distort the architecture. Okay, we can also have other things affecting the microcirculation, especially the portal microcirculation, and also provoking regeneration. And that can also distort the blood flow cause increased pressure and produce portal hypertension. Of course, it has to be a diffuse something. A localized something won't be a problem. It has to be diffuse to create portal hypertension. It can be post. And what would be a post hepatic cause? Severe right-sided failure and goes to the inferior vena cava into the heart. And therefore, anything around there can cause backflow pressures and cause post-hepatic portal hypertension. Constrictive pericarditis, it means that whatever is passing through the liver has nowhere to be pushed through, backflow issues, and therefore that. Hepatic vein outflow, we were talking of arteries being affected, not so common. Flow obstruction, like mets into the nodes, they can create this problem. Okay, what are the complications of portal hypertension? In fact, you will notice that one thing leads to the other provokes. So it's like there's a mutual effect here. So what are the clinical complications of portal hypertension? Portal hypertension is a feared state of events.
Hello? Lavin? Lek amepotea ama amemaliza?
Recording stopped.
Ati? Oh, okay. Then you begin. Oh, she got cut off. Okay.
Are you able to hear me now?
Yes, we can.
What? Okay, let me share now.
Yes, Doc, we can see now.
Okay, we were talking about complication. This always happens, so you don't know. Okay, at least I'm able to change that. Okay, so I said that ascites is a complication.
Recording in progress.
It's also a complication of the other things, and it can be massive. 500, they have an effect. It can be massive. In fact, hepatocellular and cirrhosis, and of course, even congestive cardiac failure can cause very marked ascites. And usually we have about 50 mLs of acetic fluid. look at it when you're doing postmortems, those who are rotating with us. Now, when it starts accumulating, it 10 times more or even more than that, then we have a problem with the liver. It's not producing, and oncotic pressure is not being maintained, and you are getting fluid accumulating in all the sites, and including the peritoneal cavity. Okay, it's usually a transudate, less than 3 grams per deciliter when you assess the albumin content or the protein content. Electrolytes will be similar to the one in the serum, shouldn't be very different. And then for us, we do cytology, and usually it's of not much interest. We'll only see the mesothelial cells. They can be reactive. Mesothelial cells thrive in the peritoneal fluid. So we can get them reacting because of this accumulation of fluid. But if there was a hepatocellular carcinoma, if it's due to a hepatocellular carcinoma, we can be able to have it positive. And the same fluid can go into the chest cavity so that they end up with a hydrothorax as well. We can get photosystemic shunts, where you get shunting of the blood, collateral circulation, and that's one of the things that we notice when somebody has photohypertension, that they have photosystemic shunts, and you see them around the umbilicus, and we also see it in the esophagus, and that is the most fearful one because it's the one that can bleed, and they can have massive bleeding leading to shock and death. Of course, the fluid can support bacterial growth, and for some reason, if there's a lodging of bacteria into the fluid, then they end up with secondary infection. And that is the problem of chronic liver disease, where there's ascites. They get bacterial infection very easily, and their condition worsens. And of course, that creates pressure on the liver reserve and can tip them into hepatocellular failure. When you try to figure out all this, sometimes you're not sure what came first and led to the other. They're interrelated, and most of the time the patient will come with all these effects. So even when you look at each of these consequences and other possible causes, then you realize that the diseases that we've talked about are so interlinked. One creates a problem that is the second problem, and the second problem can lead into the first problem. Not clear-cut boundaries. Because there's the back pressure and pulling of blood, there's and the spleen actually can pull blood, it becomes large. You end up with a splenomegaly, and it pulls blood, and of course, all the consequences of splenomegaly. When a spleen is large, it is subject to traumatic rupture. It is subject to traumatic rupture very easily, and so you end up with those problems. We may not go very much into splenomegaly and the issues. You will hear more about them in hematology, but portal hypertension is one of those consequences. And why does that happen? The pulling of blood in the portal system allows it to backflow into the spleen, and you end up with splenomegaly. Why is that not nice? Because splenomegaly on its own has its issues. So you see, one thing leads into another, and that new thing has implications. That's how these diseases are. A new thing, but it has its implications. So even splenomegaly has its implication, and it can be a massive splenomegaly. We have mild, moderate, and massive, and it can be massive where you have 1 kg. And what is the normal? Normal is about 100 grams, 110 grams in the mortuary, about the size of the fist. And now here you have a huge spleen that can be mistaken for a liver because of the size. And when you have a pooling splenomegaly, then you also have the hematological issues of cytopenias and especially thrombocytopenias. That is the other cytopenias, lymphocytopenia and thrombocytopenia. When you pull these cells within, then you have cytopenias. It can also cause hepatic encephalopathy because of diffusion of these toxins from the GIT and leading into encephalopathy. Okay, so how do these things relate together? I try to do a diagram to help you conceptualize what we are talking about. You have a normal liver, a large organ, 1.5 kgs, healthy. You can damage 80%, 20 will work at a steady state, and one will be okay. Then comes a chronic disease, which is diffuse, steatosis, hepatitis, alcoholic, toxin effect that is not doesn't cause massive necrosis, and you end up with a diffuse inflammation. Let me call it that: a diffuse inflammation or a diffuse interference of the hepatic function, like when you have steatosis, and therefore you don't have the capacity that was there, but you still have quite a good reserve. Okay. Then, because of this continued assault, you're not back to normal. There's continued assault on living tissue, the cells. They react. And one way is healing with fibrosis, which is diffuse and gives what we call cirrhosis. And this is not just healing with fibrosis, there's regeneration. Nodules surrounded by these fibrotic bands. Yet, the architecture is not normal. You can have a liver going back to the normal size, becoming the same normal size, but function remains at that level. You have regenerated, there's the fibrous tissue, but architecture is distorted. So sum total is that the function is reduced that way. Then you end up with hepatocellular carcinoma as a consequence of all these other things. It's the least common of all the things. Of course, there are those other things which I haven't included here, the effects, the portal hypertension, the ascites, hepatocellular failure, and what have you. And you end up with hepatocellular carcinoma. That's how these diseases are relate to each other. You can get a direct hepatocellular carcinoma without all that, and the effect will be like having a reduced function like that. Why? Cancers have their issues, they affect the entire being, and the functionality is affected. You'll eventually get derangement and what have you because of spread. And what happens is that from a good, healthy, normal liver, the hepatocellular reduces to that. And with that, I come to the end because there's no way I could have done more than that. It would have been too tiring. Any question? So you have to understand how a normal liver is, the biochemistry of how you ensure that it is normal, and then all the other effects and how they get deranged. Okay, so that's it for now. Let's see if we have a few questions that I can see in the chat. Oh, okay, let's start from the top. Yes. Somebody is asking, how is splenomegaly both a cause and a complication of portal hypertension? It's the pulling effect. If it was just a pipe, it can burst. But instead of bursting, the vessels adjust. So there's structural adjustment, not like the IMF ones, but there's distortion of the walls of the vessel because of the pulling. And because of that, they are not as elastic as they should be. and you create an effect of hypertension. That's how it works. The spleen is like a sponge, and as it absorbs this, it creates a backflow pressure, and that pressure has an effect on the wall of the vessel. It's no longer elastic, and therefore brings about the hypertension. So it's like a feedback kind of thing. Why the tumor ruptures? This is interesting. You know, the way the cells are infiltrative into surrounding tissues. They infiltrate into the capsule because the tumor has to be close to the capsule. The capsule is quite resistant, but tumor has this inherent capability of infiltrating using humoral substances, and because of that, it erodes through the capsule becomes thinned out. It becomes very thin. I don't know whether you have seen anybody in the breast clinic with a mass growing and coming to the skin until it ulcerates. There are two effects. There's the pressure effect and there's the erosion. So there's the pressure effect, squeezing it out as it grows because it continues to multiply, and then eroding through and it ruptures. There could be a related factor of pressure on it, but what we see, we just see a tear. When we look at such patients who die suddenly, I don't know how many have ever been saved, but I see the ones I've seen are at postmortem, it just ruptures and bleeds, can't stop bleeding. Even if you rush them to hospital, it's like liver rupture following road traffic accidents. So that's what now can happens. Pressure effects and erosion by infiltrative tumor cells. That's how the tumor ruptures. Somebody wanted to know how that happens. So it is thought to be as spontaneous, but it's because of the effects such as that. FNA, you're using a needle. Core biopsies, you're using special needles which cut a bigger tissue as opposed to a needle which loosens cells, and you get fragments of cells rising up the needle by capillary pressure. But the core, like the bone marrow, you're twisting a wide bore needle that cuts through the tissue and gives you a core of tissue. Yet the FNA is actually loosening cells which are carried by tissue fluid through the needle, and we suck them out as cells and fragments of cells. How does liver cirrhosis cause peptic ulceration? How does liver cirrhosis cause peptic ulceration? That one I have to work out, but it does. It actually does. We can check that one up. I can't remember it offhand how it causes peptic ulceration. Besides the stress factor, but it actually does. Explain hyper. I said the adrenal cortex, the adrenal cortex has three areas: zona fasciculata, zona glomerulosa, and zona which one? One of the zones produces the sex hormones, and those sex hormones have estrogenic effect, and therefore they are usually metabolized in the liver. And now, when the liver cannot metabolize them because function has been reduced below a steady state, then what happens is they accumulate and they have an effect. And in the men, they have enlarged breasts. So when we have a female, the male, when you have a male coming with gynecomastia, most of the time we want to see that they don't have a cirrhotic issue or they don't have problems with the testes. And that is just that it's not being metabolized, but it's still being produced by the adrenal cortex, the adrenal cortex, one of the zones of the adrenal cortex. Zona fasciculata reticularis, and I've forgotten the third one. There's one produces the glucocorticoids, the other one produces adrenal, what is it, aldosterone, while the other one produces the sex hormones. Okay, what are tumor markers for hepatocellular? Alpha-fetal. We have others, but they are not specific because we have other tumors that produce them. What happens is that if you establish somebody has hepatocellular carcinoma and you do the alpha-fetals and they are high and you monitor the patient, you will know the medication is working when they start coming down. But if they continue rising, then you know they have meds. But on their own, I mean, alpha-fetoprotein can be due to many things. We said even the cirrhosis, massive liver necrosis. Yeah, so not a very good one. Not a very good one. How do we know when to use FNA or core? We don't use FNA anymore. We don't use FNA anymore. We use core because the core, it's like the breast. If we are suspecting a simpler lesion, we use FNA. But if we are thinking of malignancy, then we do core. So for liver, most of the time, we do core. We rarely have to do an FNA. If it is the acidic fluid, of course, we'll use a needle. But if we are suspecting hepatocellular carcinoma, then we go for core biopsy, not FNA. Of course, you can cause massive bleeding. That is one of the complications. And before you do biopsies of the liver, you have to do the INR. You have to ensure that the blood will clot, that there's no effect on the coagulation factors. You remember they are proteins, they're produced by the liver also. So you have to ensure that INR is okay. That is a requirement before we we do a core or even do an FNA if need be. But today we advocate cores. We don't usually do an FNA unless you're suspecting something like amoebic liver abscess. But if it is a tumor, we don't do FNA. We prefer a core biopsy. Okay, and with that, I think we come to the end. If you have any more, you can send them to me. I'll be able to answer. Okay, I'll take a break until we meet again to discuss, I think, the ovary, female genital tract, the ovary. Okay, thank you.